Hello.
Hi.
Stacy, how are you?
Busy.
I think I work double being online. It's like it never ends.
I have to agree with you. It's a little more stressful.
Yes. Yesterday was, I had 4 online meetings yesterday. I taught in Morgan in the morning. I had a conference with my director, another student at 8:30, taught at 9:30 to 12:30, had another meeting, and then I had my class that I'm taking, and that was brutal because I don't understand the work. And we were talking, it's some kind of statistic stuff that I'm just barely hanging on by a thread. All right, let me see who all is here. Mindy, hi Mindy.
Hey, how are you?
Good, how are you?
We're doing pretty good. Doing pretty good.
Stacy. Sylvia, hi Sylvia.
Hi.
How you doing?
I'm good.
Hey, Sylvia, Amanda. Hi Amanda.
Hi,
How are you?
I'm doing good.
Hanging in there?
Yeah.
We have one student coming from the day class today joining us. She'll be with us too. And tomorrow we're going to do post-conference afterwards today so that you guys don't have to join tomorrow for pre-conference, I mean. Tomorrow is Alice training, but it's not really, it's civility now. Make sure I have your schedule here. Oh, here's Jessica. Hi, Jessica. Hi, Ivana. Oh, Jessica's still connecting. Who are we waiting for yet? Rashida, Dave, Carol, and Jenna. And you guys know this is a recording, so it's kind of if you listen to it afterwards, you have to go through all this stuff in the beginning. All right, while we're waiting for people, I'm gonna just kind of get my PowerPoint around. All right, so I'm just gonna move you guys there a second. I don't know if you can see that you're being moved or not. I'm just minimizing it just for a second. Oh, you cannot minimize when you are recording. Okay, never mind. I guess it told me. All right. It's opening up in the background. So while we're waiting for everybody else to join, how are things going with everyone? Anybody feel like sharing anything? Questions, concerns?
I have a question about the civility training, and I think you'll probably have to say this again when everyone's on, but do we send it to you?
No, that goes to Barb, and it should say that, right?
Oh, okay.
I don't think so.
All right, let me pull it up and see. You guys can see that, right? You can see this, right?
Yes.
Yeah. I sent it to Barb, but she said that we had to send it to Katie Shane.
Oh, okay. Let me see what the directions say.
I think because we're evening, everything goes to Katie.
Yes.
Oh, okay.
But did you want us to do anything with like the Dropbox?
No, I actually took that down.
Okay.
Okay.
All right, I'm just going to email, or I'm just going to text Ina and just confirm that. Let me see who else is coming in. Here's Dave. I'm just gonna text her real quick. PM sending civility to Katie Shane, you said, right?
Yes.
All right. I just sent her a text, so we'll see what she says. But if that's what she said, it's probably what it is, but
So Amanda, did you send the certificates and then like the debriefing, or what did you send?
I sent the certificates and the debrief. I sent all of it to Katie Shane. I mean, to Barb Morrison first, and then she just responded and said that because we're in the evening program, we had to send all of it to Katie Shane.
Okay. Just making sure I have the right things.
and I just texted Professor Levin also, so we'll see what she's, she's probably going to say the same thing. Let's just get to, all right, Alice training. Okay, all right, so here is, so Alice training civility modules ×4 foundations of professionalism and civility in the academic environment, civility and patient safety in the clinical environment, professionalism. All right, where is that's all I have.
Yeah, that's it.
Do you guys understand what that means?
Yeah, they're just 4 modules on ATI.
Okay. Because I didn't make the assignment. So once she gets back to me.
I think under
Ina's.
keys, yeah, there's like a Google Docs, or not a Google Docs, Word document that has some more information of
Okay.
like post.
Okay, I will find that out. Let me just write myself a note to just, if I don't hear from her while before we're teaching, I'll just clarify it on our thing. Okay, civility. Send to Katie, because do you guys have Katie's email?
Yes.
Yeah.
Okay, because I'll try to update this with the emails and stuff. So I'll try and do that for you guys if I can get that. And then the next, I'm just looking at the schedule here. So that's Thursday. And then Monday, we're going to do pre-conference at 4:30. And that's for the simulation and NICU. But if anyone wants to join in on Monday the 30th, if anybody wants to join in who's doing simulation on the 6th, you're more than welcome to. And then if you want to get started on that early, it is posted up there, but just so to go over it, if we have time today, I can try and go over it a little bit, but we'll see what kind of time we have. But I wanted to kind of go over a little more in detail. I think everybody is here. Let's see, is Jenna? Anybody here, Jenna?
She just texted me and asked if class was open. I said yes.
Okay.
Where is the pre and post simulation?
Okay, I'll show you here. Let me get out of this. Go into your modules. Gonna make you dizzy. Okay. Here is the pre-simulation. So here's the pre-sim learning packet. And then that'll go through, it's probably Jenna now. Yep. That'll go through, the directives. And clearly, you're not going to be taking this, you're not going to be bringing this to class. This would have been a ticket to enter. So it's just going to kind of take you through. And to be honest with you, a lot of the lecture today is all right in here. Yeah, most of this is today's lecture. Yeah. And then, your medications. So this is your packet. And then when it says like complete the home visit simulation, complete the game and upload to Canvas. So then that is, how do I get previous? Okay, and so when you look at that, it says it can't open. Don't go there. This is your hyperlink up here. So you click onto the home game, and then you go through the modules. It's pretty cool. It's actually, if you do something wrong or if you give her the wrong answer, she can get snarky with you. She's like a little virtual person. So you go through, there's 3 modules, and then there's a simulation game. So you would do that, and let me go back to previous again. That's not where I want to be. Well, I might as well go over this while we're here now, then we got this part done. Okay, pre-sim, let's go back to pre-sim. Okay, so where was the packet again? All right. So you went through the postpartum hemorrhage stuff, and then you go to the home health stuff, and then you're gonna go on to the playspent.org, and you're going to go through those scenarios and then answer this question: how did that help you with your patients? So I'll just give myself a note, and I'll show you those sites in a second. So PlaySpent. And then read the home visit article, which is on there. And then go onto the link and through, go on the link and read through what you would expect from a home visit. And then it has some questions here based on a home care, because these were the sims that we were going to be doing. And then the next one is routine newborn care. So you're going to go through the simulation. So you're going to watch these 2 videos. And then this actually would also take you through what today's lecture is, what's the initial priorities in immediate care of the newborn. So you're going to answer these questions, ask your vital signs. Again, a lot of this stuff is off of today's lecture, all that stuff. And then in here, you're going to fill in, like I put some stuff in there. You're going to fill in like the priority, problem, intervention, expected outcome. So that's your pre-sim. And then let's see if it takes me back now. I don't know why it doesn't take me. Oh, there we go. Now I'm getting it. Okay, so then when it said to go on to playspent.org, it says you're trying to, just ignore that. You go into here. This is actually pretty interesting. Again, a lot of these are like gaming things. So then you'd go continue to there, and then accept the challenge. And then it goes through this whole thing there. And then let's see. I showed you the home visit, the pre-sim, play-sim. There's the home care safety stuff there. There's the Dropbox where you would put everything into that. And then there's the video for the home visit. And then you're going to come down to simulation day, because these are all things that we would have been on campus for 6 hours doing all this stuff. So you need to go down here and then go down into the simulation day document. And then I kind of take you through what simulation would be. So you have to understand when you read through this, you're reading it as if you were in the sim lab with me that day, because that's how it was designed. So obviously you're not splitting into groups. You're not going to LB 120, but I didn't change that part. I have all the objectives. This is just what you're going to be learning. And this I need to have, well, I had to have it for sim, but I also have to have it for the State Board of Nursing. So these are just all all the objectives that you're going to be getting. So then you come down to avatar simulation, and then you're going to go into the maternity series simulation, and you're going to do these 4 simulations there. And then complete the modules and the games. And then at the end, you'll get a game report. It'll tell you how you did on the games, they're not really games per se. They're actually, you're doing simulation, virtual simulation. And then you're to pick one of the 2 articles. Please do not read both articles. So you're just going to pick one of them. The one article is the role of the nurse in combating human trafficking, and the other one is care of the woman in the criminal justice system. So pick one article that is interesting to you, and you're going to read the article and you're going to answer the questions. Now it says to put the answers on the Scantron, and I was going to collect them. Clearly, I can't do that. So just put that on a Word doc. You don't have to type the questions out. Just write number 1, and it's multiple. I think there's like 12 or 13 questions, right? Number 1, C, number 2, B, number 3, A. Does that make sense?
Yes.
Yes. And then can we submit all this weekend?
You can submit it as anytime you want. Yes, absolutely. No, it's not where I want to go. I just want to show you the articles and stuff. And everything is here for you. All right, so here's simulation day. So there's care of the pregnant woman article. There's the quiz that goes with it. And I'll just pull one up to show you. So like, there's your article. They're actually I find them really interesting, but that's just me. I like reading. So there's your article. And then, I'm not sure why it's not letting me go back for whatever reason. There it goes. Okay. And then there would be your quiz. If you are an LPN and you have to get continuing ed credits, it does actually offer that. So that's there. So this one has 18 questions. And there's the questions. I was like, wait, where's the questions? There they are. They're all multiple choice. All right, and let me see if there's anything else I want to show you on that link. Okay, so there's your articles. 1, test, other article test. There's the maternity series simulation. And there is your drop boxes. So when you go into the maternity simulation, again, it's going to look like you can't open it. You have to go up to this hyperlink up here. So you click onto here. And then there's your 4 scenarios. There's the kind of, I'll see if I can take you, I don't know if it lets you go right to the game. Just to give you a quick idea, I've played this before, as you can see.
Hello, I'm Georgia Graham, a registered nurse. I'm here to assess you before you see Sue Huang, the nurse practitioner. What would you like me to call you?
I'm Madison Frazier, but Maddie is fine.
So then it says, how should you proceed with the interview? Okay, I'm just going to give you a little sneak peek to see if see how she gets snarky with you. So I'll give you the answer. So it gives you options on how you should respond. So let's say we're going to congratulate her. Okay, we're going to say, oh, she came in, she's pregnant. Let's say congratulations on your pregnancy.
Oh, I see you're pregnant. That's great. Congratulations.
Sorry. I don't want to start crying, but I don't know how you can say congratulations when you don't know my situation.
So then it gives you feedback, tells you like, if you answered this way, this is how, so that's kind of how and that's how all those scenarios go. So you'll go through the modules, you'll go through each of the modules, And this one, it takes you through prenatal care. It kind of takes you through everything that we've talked about pretty much, so through the whole thing. And then the labor and delivery one. So this is kind of cool because it takes you through almost everything that's on your exam this coming week. So it talks about fetal monitoring, your first, second, third, and fourth stages, pain management, obstetrical emergencies. So it's, I think they're,
Pretty cool.
it is really cool. So that is your sim day. Do you guys have any questions about that? And Ina, you're joining us too, right?
Yeah.
Okay, so you kind of heard it too. So I think for days you don't have that for a while, but what I'll do on Monday is I will be open. I'll open the office hours from 4:30 to 5. If anybody has any questions, but if you're okay, that's pretty much what your sim day what your sim day packet would be.
Okay.
So if you guys are fine, you don't have to join me on Monday since I went over that, and the people who are on April 4th, the same thing. But I will stay open for the office hour for the first half hour just to see if anybody has questions as they're going through. And then the NICU one, because I think there's a couple people with the NICU. So let me get the NICU pulled up.
While you're doing that, I have a question. This is Carol.
Yes.
Can you hear?
Yeah.
Okay. I'm not sure exactly what we're supposed to put in the Dropbox for the sim.
Well, when you start reading through the packet, it's going to tell you, please upload, like it says, go onto this website, do this game, please upload that. So like I didn't read through every single thing, but when you read the directions, it tells you, please upload this, please submit that. So it'll tell you in the directions. You just have to go through, read it, and do what it asks you to do. It's kind of like step 1, it's kind of like making a cake. Not really, but step 1, do this. Step 2, do this. That sort of thing. But again, I will be available as you're going through it if you have questions. Don't hesitate to ask me. And then NICU, did that answer your question, Carol? Yeah. Okay. And then NICU for Monday is Jenna. So here is the directions for the NICU. So you're going to go on to, and the enteral feeding, I put an hour, but to be honest with you, it just really depends on the student. I've had students who told me they went through it in 20 minutes. I've had students who told me it took them 2 hours. I just really think it depends on the student. It's designed for an hour, but again, it really depends. So you're going to sign on, you'll go on to the learning tab, you'll click onto the enteral tube feeding, and then there's a pre-test and a post-test. So the ATI, I think you guys kind of get that idea right now. ATI, Michelle Cohen is going through and checking off. So what she did was she made like a Excel spreadsheet. So she has like all the, she has like the clinical schedule. And then I gave her the updated one. So she knows what everybody's doing. Then she just kind of puts a check mark that they got it. And you want to aim for an 80%, which I should probably put on there. And then written assignments are to be emailed for OB to Dr. Reisman. And then this one, you're just answering these questions this one here related to the enteral tube feeding, which we will talk about in 2 weeks. And then read the article. There's a nursing and NICU article, which is on the link there. And then you would answer those questions and then do your debriefing. And that's your NICU assignment. So that would be for Jenna for Monday, the 30th. And then it would be for Sylvia on Monday, the 6th. So I think we kind of got everybody covered. And then Monday to 6th, the only other one would be whatever I gave you guys for KR. There was 4 of them. Does anybody remember what you were given for Monday the 6th if you had KR? So let's see, it would be Jessica, Angie, Rashida, and Dave. Does anybody have your schedule handy? Oh, Jessica, you're muted.
I have, it says gestational diabetes, ATI.
Okay. So let me just show you that one really quick. That's the very first one I made. Okay. Okay, so kind of similar. You'll go onto your ATI. And all you're doing is gestational, Jessica. And so it'd be Jessica, Rashida, and Dave. All you're doing is gestational diabetes. Don't do any more. I had a student who emailed me, and the student did the entire every single module. So they did gestational diabetes. They did postpartum hemorrhage. I mean, they did like, I think there was 6 of them. And they said that they were working on it for like 8 to 10 hours, and I couldn't figure it out. And then Michelle Cohen said, you have a student who finished every single module in the whole entire thing. I'm like, oh no. So just all you're doing is one, so it shouldn't take you that long. And then Michelle will look over the ATI, and then you have the pre-module assignment, which kind of goes along with that. When you're doing these ATI templates, if you've noticed, I don't know if you saw for peds, these are basically right out of your ATI book. So if you look at your ATI book, either electronically or one of the students has a hard copy of it because they came from a different school, it's pretty much, it's right out of there. Some students know their stuff very well, and so they're gonna go through it really quick. And other students, they might, they're not quite sure about certain things, so they're not going to go through it. But does everybody at this point should know how to access your active templates, correct? Because I know that PEDS is using the same form, like the same format. And then your debriefing questions down there. So that would be for April 6th. And the same thing, I'll stay open, but I'm not at this point. If you're good, I'm not going to, at this point, as long as no one has any questions, it won't be mandatory to log on for pre-conference, since we kind of went over those. But I want to be available for you if you need me. Let me just see. Okay, so Professor Levin said, yes, all evening clinical. And all evening clinical are going to Katie, and all day clinical is going to Barb. So Ina, you're going to be sending Barb Morrison your Alice training stuff, and everybody else you're going to be sending yours to Katie Shane. All right.
Are we talking about the Alice training after class? Is that what that was today?
That's what we were just going over now. So that's why they asked me if I would start right on that, so I figured I might as well.
Oh, okay.
Did you hear any of it or not?
Yeah. Did I hear any of the Alice training?
Mm-hmm.
Did you do it in like the first 2 minutes?
Yeah.
No, see, I couldn't find the Zoom link, so I missed.
Okay.
If you have a couple, do you mind?
No, I'll stay on. But let me just show you guys, just to help you. I'm in the PMs, right? So I have the Zoom link right here. So if you go into Canvas under virtual clinical, I kind of put it right there for you.
Yeah, I opened your office hours one, and I was like, oh, she must be in office hours.
Sorry about that. Yeah, so I think I might have had that initially. I was like, oh, I'm not sure. So I thought so I threw it right on there so that you guys could just go right in there.
Okay, good.
No, so stay on then, Jenna, when we're done, and I'll go over that with you.
Okay, thank you.
You're welcome. Does anybody else have any questions? Everybody's good? All right, so we're going to get started. I took some stuff out of the PowerPoint. So we're not going to be covering postpartum depression. And I'll kind of go over that. So we're not going to be covering that. Also, let me just say thank you to her. When we have a break, if I can find it, I want to find this email to share with you guys, or I'll just kind of verbally share it with you, and then I'll tell you when I find it. But let's get started here. Okay, can everybody see my PowerPoint? All right. And then just raise your hand if you have a question. We're a small group, so you can ask me. All right, so I got some confirmation. I had originally sent out an email to everyone that you make sure that you're present for the ATI live review. And then I had some students asking me if they're graduating in August or December, do they have to attend this? And the answer is no. So if you are a May graduate, if you're finishing your program in May, then you need to attend the ATI live review, which is April 27th through the 29th. If you are finishing your courses in August or you're finishing your courses in December, then you do not. Is everybody good on that? PowerPoint presentation, how's everybody doing with their groups? Carol's saying not good. They're not responding to you, or do you want to chat separate, or just?
It's just hard to find time to get together. We have a bunch of stuff compiled, but
Okay.
we really haven't gotten together to finalize everything.
Are you guys using Google Drive to share all your documents so that everybody can add to it?
Google Doc, I think it is.
Yeah. After this exam's over, we're gonna pound it out.
I think I posted it on announcement. There's a ton of stuff on announcements, but there, Rick Paterick and all library resources are still available to you. You have Rick Paterick's email. He will be more than happy to work with you. He's working remotely as all of us are. So just email Rick. If you don't remember his email, there is a PowerPoint, or you can ask me, and we can get there. I know a student in the morning said they were having a hard time finding nursing literature on their content. And I said, so my first question would be, did you reach out to Rick? And they said, no. I said, okay, go ahead and reach out to Rick. After Rick works with you, if he can't help you find something, he will send me an email and say, Carol and Jessica were working with me. This is their topic. We couldn't find anything. I did find stuff for them, but they're not in nursing journals. And then at that point, I say, yes, you may use them.
We have our journals. We just have to pull all the information out and put it together.
Gotcha. Okay. So, just communicate with me if you have any questions. Communicate with me privately if you're having issues with your group. I always say there's always going to be group issues. And I always say when students come to me about group issues, the first thing I say is, did you communicate to that person that's maybe not cooperating or is not doing their fair share? And then at that point, because I don't want to go to a student and meet up with them and say, well, I'm being told that you from your group that you're not doing anything, and they're like, I never knew that. They're like clueless. So I don't want to go to a student unless the students have gone to the student first. I know it's uncomfortable sometimes, but unfortunately, we all collaborate, especially as you go further into your education. So if you're not sure, reach out to me, reach out to Rick. Don't forget when you are working to stay with that rubric, because that's really what I'm going to be grading you through is on that rubric. We talked about clinical. We went over some different, some things with the clinical. Check your emails, check your announcements. I know you probably can't stand seeing emails from me anymore, but that's the only way I can communicate with you. So, Carol, yes.
I just wanted to say that our group is good. We do work together. It's just finding the time to collaborate. But like Jess said, after this exam, I think it will we'll all free up a lot of time and hammer it out.
And you're not the only one, Carol. They were saying the same thing. I had some students from my day group emailing me, and they said the same thing. And I was willing to do a Zoom with them after class today. And they're like, no, we want to spend time studying for exam 2. Can we, if we're having problems, can we meet after exam 2? I'm like, that's fine. So no, that's understandable. I completely get that. When I first started my online classes, both my master's and my doctorate, we had to do online groups as well. And it's weird. It's weird. It is difficult when everyone's working full time. I completely get that. It's not, a lot of stuff that you're going to be putting into your PowerPoint, you're making up. Like when you look at the beginning part, you're creating a person. You're just saying, Jane Doe, 35-year-old, gravida 1, para 2, came through the emergency room complaining of right lower quadrant pain. She's currently 32 weeks pregnant. Like, you know what I mean? So you're just like, some of that stuff you're just kind of making up, and as you're going through, obviously you have to back it up with stuff. I want to tell you guys that you're doing a good job. Everyone is doing what they're supposed to. I'm not, Michelle has been sending me feedback. She says everyone's answering her emails. Everyone's getting back to her. You're handing everything in. You're communicating with me. If there is an issue and you can't get something done, the best thing to do is don't, if you need an extension, I work with students, but you have to reach out to me. So like if something is due and I don't hear from anybody and then they hand it in a week later, that's late. But life is going on right now. Life is really flipped around right now for all of us. So I'm very flexible in your needs and trying to help you. I just want to make sure you need to have everything done before the end of the semester, obviously. But definitely you're all on track. You're all doing well. So right now, what I want you to do is pat yourselves on the back. Give yourselves a good pat on the back. Tell yourselves you did a good job, and reach down to one of the other people on the screen and give them a pat and tell them they're doing a good job. So kind of like, do you remember Hollywood Squares? Well, Ina probably doesn't remember Hollywood Squares, but in Hollywood Squares, everybody all had little screens and they'd all like reach down. So tell one another that they're doing good. One of the things that it's so easy to get caught up in the negativity, but we want to support one another. We want to, acknowledge when people are doing good. So definitely, make sure you take the time to tell someone they're doing a good job.
Or hugs to everyone.
You're welcome. You're welcome. Exam 2 will be next Wednesday. So it's going to be April Fool's Day. What an April Fool's joke, right? Exam 2. So your exam will open at 4:30, and anybody who has extended time will have that time built in. I'm going to put a practice exams, and I'm going to set up a practice exam probably tomorrow morning. I'll post that so that you can make sure that Lockdown Browser and Respondus are working. Make sure you log in about 10 minutes ahead of time to kind of start getting everything ready. And you can thank your Morgan group. They asked me if I could extend the time a little bit for the exam because they said it takes a few minutes to show your ID, do the scan of the room and everything like that. So I'm going to extend it 15 minutes. So it'll be 4:30 to 6:45 p.m. And then if anybody has extended time, that is added into there. So for those with no extended time, you'll have 2 hours and 15 minutes. And that should give you the time to do the scanning of your ID. And also I built a 5-question case study. And I think you might need trust me, they're students do very well on it, but I want you to be used to a case study because you're going to get case studies in your NCLEX this summer. So I built one in. It's not difficult. It's based on your content. It's nothing foreign. And there's 5 questions that go with that. So just because it's a different format, I want to give you a little bit of extra time on there as well. I don't really think that you'll need that much time, but it's there. There's going to be, I want to say, I think there's like 93, it's 100 points, but some questions are worth like 2 points. So I think there's like 93 questions or something like that. And then I'm going to talk a little bit more about the exam after this content as well.
I had a question about the group project date.
Yes.
So on the Dropbox and assignments, I was doing like all my due dates. It says it's due the 12th, which is like the Easter Sunday. So do you want the PowerPoint uploaded by the Sunday the 12th?
Yeah, you're going to do. You'll do the PowerPoint because we're going to present the 15th, right?
That's what I was wondering. So we're going to present the 15th, but it has to be uploaded by that Sunday.
Yeah, because I need time to go through and grade everything.
Okay. Yeah, no, I was just double checking.
Yeah. So you'll do both. You'll upload the PowerPoint and the paper is no more than 2 pages. 1 to 2 pages is all you're doing. If you look at the sample one online, you're just basically summarizing.
Okay.
Everything. I don't know if you guys can hear my dog snoring over there or not. Do you hear? Yeah, Carol's saying it. Shh. And she's deaf, so she won't hear me anyway. Okay. All right, so it takes me to my next point here. And this is my goal. This is Professor Levin's goal. And this comes down from the president down to Dean Kohler, down to Tina Van Buren. We want you graduating. If you're a May graduate, we want you graduating. You're going to be taking your final exam for me on May 6th. I want to put your grades into Banner by May 10th or 11th. And I want you to be able to start your process for taking NCLEX. I would like my goal, and you can do it sooner, but my goal is I would like the students to be able to finish what they need to do as far as getting the green light. And then, we'll talk about that more at ATI, on your ATI live review. We'll talk about that process. But I would like you to finish everything. And if you can start taking your NCLEX in June, that's great. July, but July, I think it'd be totally doable. So I'm going to do everything I can on my end to give you everything that you need. And then I just need you to do your part. And then we can get you to graduate to be RNs. That's my plan. We all know right now we need you a lot out there. Even without COVID-19, we need you. And we especially need you. And we want you to be well and safe as well. If there comes a time where you think that it's just way too much going on and you feel like you might need to step away, that is a conversation that you can have with myself, with Tina, and go that route. We are literally 5 weeks left. All right, guys, 5 weeks. So we want to see you finish. We want to make sure that you're successful. Everybody was emailing me about their Zoom. They got these emails from Irv, from L-Tri-C. Everyone was given a Zoom account or the opportunity to open a Zoom account on your own. Zoom is actually very pricey. You can get it for free, but you can't be on it for more than 40 minutes. So you were all given as spring credit students, you were all given an email. And Mindy's kind of looking at me, huh? It might be buried in there. It might have it shouldn't have went to spam. But check your email if it's something that you're interested in. It's really good to create an account. You can create it with your own email and stuff like that. And then you can meet. So Carol and Jessica, you guys can meet via Zoom and work with each other as well on your project. And just a little side note, I'm sure a lot of you aren't seeing your families. So it's a really good way. I Zoom, it sounds really weird to say I Zoom. Like never in my life would I say such a thing. But I've been Zooming with my grandchildren every day. I read to them. Matter of fact, what did I read today? Where are the wild things? So every day I go on there. And today was wild animal theme. And I just go on for like 10 or 15 minutes and just see my grandchildren, talk to my kids. I can't do it for real long because I'm spending a lot of time between this and my classes and stuff, but it just, you need to stay connected with your loved ones, your really close friends and family, because sometimes social media, as much as it can be nice, there's a lot of crap that goes through lately. It's like, I look at it, I'm like, why am I even sitting here reading this? Like sometimes it just brings you down. So you can use that and meet up with your family as well. I don't think there's any restrictions on it. Use it to help work with one another. You can use it as a study. You know, if you guys used to get together at the library and study for an exam, that's another way. Clinical assignments, I said keep a log. There was a couple of students that said it was taking them a long time. So I said keep a log. Like say, like I'm just going to use day students for example. So they have to do 6:45 to 2:15. So I said when you log on at 6:45 to start doing like say your GDM assignment. Say, you know, keep a log. I started at 6:45. I went from 6:45 to 10 o'clock. At 10 o'clock, I took a 15-minute break. I started back up again 10 o'clock to noon, took a lunch break from 12:30 to, and if it looks like they're working and, you know, you're working until like 7 o'clock at night, there's something, you know, I need to know. So I need to know if that needs to be tweaked. So if you're finding it's taking you a lot longer, just, you know, next time you're working on something, keep a log. And, you know, I mean, I did the first assignment, I did the GDM, but Tina Van Buren brought up a really good point. I know my content. I know, you know, I teach it. So when I go through and do it, I can go through pretty quickly because I'm not learning the content. So if you find yourself in that situation, just email me. Only a few people email me, and a couple of them, they actually worked way more than they needed to. They did actually more than the assignment was asking them. So then when they realized they did a lot more, I was like, you didn't have to do that much. But just, you know, just communicate with me. So pre-conference, so is everybody good for tomorrow? Minus Jen, I'm going to work with Jen afterwards, but is everybody else good for tomorrow for your ALICE training, which is now civility training, really? And is everybody good for Monday for your simulation? Okay. And then just to put here, stay positive, and use that Q&A section on Canvas. If you have any, do you guys know what I mean by the Q&A section? Okay. All right, these are the objectives. We're going to take out number 3. I'm not going to include postpartum depression and all that. I'm going to make that its own, because I realized it was kind of hefty with, we're doing postpartum hemorrhage and we're doing newborn assessment today. And so in module 3, it was a little bit lighter. So I took the postpartum stuff out, and I'm going to add that into module 3. And anything that talks about respiratory distress in here is going to module 3. So that stuff, and you'll see that you have a revised PowerPoint. You guys all know there's a revised PowerPoint? Okay. All right. So we're going to talk about postpartum hemorrhage. We started talking about it last week. And just to give you an idea, so the amount, you know, women when they deliver are going to have a certain amount of blood loss. If a woman has a vaginal delivery, if they have a vaginal delivery, their blood loss is about 500 milliliters. If they have a C-section, their blood loss is about 1,000 milliliters. So knowing that a woman who has a C-section has a larger amount of blood loss, what does that put the woman at higher risk for? So she's losing more blood, and we know, very good. It's going to put her at increased risk for postpartum hemorrhage. So that's going to be one of the risk factors for a woman with postpartum hemorrhage is C-section. So the way we handle postpartum hemorrhage is 2 parts. The first part is we need to treat what's going on. So we need to eat, you know, massage her fundus if it's boggy. We need to give her some type of a uterotonic medication to get the uterus to contract. We may need to give her fluids, blood, whatnot, but we need to treat whatever's causing it and take care of the hypovolemic shock that she is experiencing. The second part is we need to determine what caused the bleeding and take care of that cause. So it's kind of a 2-part. It's basically the immediate need and the secondary immediate need. Does that make sense? So in the second part, if she had some retained placenta from her delivery, then she would need to go to the OR and they would need to do what's known as a DNC and get that retaining parts out. If she had like a uterine rupture, depending on if, say it was a very severe uterine rupture due to like a placenta previa, she may need to have a hysterectomy. I'm not saying she would absolutely have to have it, but it may be so severe that she would need that. So I can't really tell you like what type of operation, because it really depends on what exactly was going on. So this actually goes right along with your pre-sim pack. So one of the questions in your pre-sim pack was, what is the 4 T's, or the 4 primary causes of postpartum hemorrhage? And they're known as your 4 T's. So the first one is tone, and that is looking at the uterus. Is your uterus boggy or is your uterus firm? The next one is tissue. So it's looking to see if you have any retained placental fragments. The third T is trauma, and that is any lacerations. Maybe the woman delivered a large for gestational baby. Maybe she had pelvic disproportion, which means her pelvic inlet was not suitable for the baby, so she had a lot of trauma and damage to delivering the baby. And then the last T is thrombin disorder, so any type of clotting issues. This list is pretty long, so I'm going to tell you what I would say would be the key things that I would want you to really focus on. So for your risk factors, we said one of the risk factors is a C-section, right? So we talked about a C-section. So I would highlight your previous C-section. Another one we said that caused severe bleeding and they'd have to go to the OR is placenta previa or placenta accreta. Another one would be halfway down is having a prior history of postpartum hemorrhage. So if the woman had a prior history of postpartum hemorrhage, it puts her at increased risk for having a postpartum hemorrhage with the next pregnancy. A vaginal, I'm sorry, not a vaginal delivery, but a delivery where they had to use forceps or a vacuum, because that's going to cause trauma to that area, or it can potentially cause trauma. Another one would be any augmented or induced labor. So if we have to like induce labor, say we're using oxytocin takes the risk of causing hypercontractibility with her contractions. That is going to increase her risk for postpartum hemorrhage. And the last one I want to talk about is precipitous labor. And what does it mean by precipitous labor?
Labor in less than 3 hours.
Correct. So why would labor in less than 3 hours increase her risk for postpartum hemorrhage?
She's not going through all the cycles, so everything's just happening so quick. She doesn't have time to like fully go through all the stages, like where she dilates, and it's just really fast.
Right, and what is not happening as much versus a traditional labor?
She's not as contracting as much. Is that what it was?
Right. So Jessica, you were correct, and who was that?
Jenna,
sorry.
So both of you. So both of you are correct. So I was just looking for that added piece of the contraction. So in the precipitous labor, the baby's coming out so quickly that she's not going through the contractions, which the contractions are going to be helping stop the bleeding. Okay. So let me just re-summarize the ones I want you to know. So previous C-section, prior history of postpartum hemorrhage, up at the second point, placenta previa accreta, the forceps or vacuum because of the trauma, the augmented or induced labor, and the precipitous labor. I mean, all of them are, but I'm not going to sit there and make you memorize like 50 million things, but just keep that in the back of your mind when you're reading NCLEX questions. They are some of like, if you're reading, not even just for my exam, but even for your NCLEX, they're going to say this woman is 38 years old. She had a previous history. She had a precipitous labor. She had large gestational age. She had, I don't know, something else going on, whatever. Maybe initially they had, induced, I don't know. Her blood pressure is this, her, 2 hours after delivery, her fundus is boggy. They're just kind of setting the scene there for you. So management, I moved, if you have your notes in front of you, if you printed your notes, I had fundal massage underneath at the bottom. I kind of put it up to the top because I want to get you thinking, what would you do first? So let me give you a little scenario. So you go to see your mom who delivered 2 hours ago. What is the very first thing? Think about last week's lecture about your postpartum sentence. What is the very first thing you're going to assess on the mom?
Fundus.
Correct. So you're gonna assess her fundus, and you're going to feel her fundus, and her fundus is boggy, but it's not deviated. What would you do then next?
Massage it. She shouldn't have to void if it's not deviated.
Correct. So now you massaged her fundus and it's still not firm. What would you expect to do next?
Administer a uterotonic.
Bingo. What are some of the uterotonics? Anybody can help her out. Go ahead, Jessica.
I would say the oxytocin.
Oxytocin's one. Good. Another one begins with M. Carol?
Methergine,
Methergine. Good. Another one begins with H.
Hemabate,
Yep, Hemabate. So you're going to administer one of those oxytonics. We want to probably be increasing her IV fluids. We might even run her IV fluids wide open. We want to obviously make sure we have a decent size IV line, because she might need what? What else? What might she need? She's bleeding out.
She might need blood.
She might need blood, right? So we want to make sure she has a good size IV access for that. And then if we did all those things and nothing worked, at that point we're on the phone and we're calling the doc, and we're going to be getting her to the OR and getting a urinary catheter into her and starting surgery. Hold on once. I'm just going to open I locked my dogs away, but she keeps scratching. So I'm just going to make sure that she's good. I'll be right, like 2 seconds. You girls better be good. I'm sorry about that. They're usually pretty good, but she probably had to pee. So anyway, after you do all those and nothing else is working, then she's going to need to go to the OR because we're not able to control that bleeding. Does that make sense? Any questions so far? Okay, so here's our medications. So oxytocin's one. Your methergine is another one. Your methergine can be given IM. Your methergine and your hermabate, you can actually repeat. You probably remember me talking about misoprostol or Cytotec. Remember that little video where that was given per vaginal? Remember that little video where it went in and it showed you how, because we use that also as an induction agent as well. So a lot of your induction agents are also going to serve as your treatment for postpartum hemorrhage. Does that make sense? Because they're going to be causing this contraction. So in induction, we want to cause the contractions to get the, to deliver the baby. But in postpartum hemorrhage, we want to cause contractions to clot off the blood. Jess, you look like you had a question.
Yeah, I did. I don't remember if I saw it in something we watched. I thought I read for the hammer bait. Does that affect women with asthma?
Yes. Yes.
Okay, so
And also cardiovascular. I think that was one of those ones where I think it was in our lecture last week.
okay.
I think that I had that in my notes, if I remember correctly. Good question. Anybody else have any questions? And then also you want to make sure that you do a type and cross and be ready to administer blood. And I put here just to revisit blood administration. I'm not looking at anything crazy. I'm just looking at very basic things. So basic things would be having a type and cross. When you're administering blood, what is the RN's role when you administer blood? Go ahead, Jess.
You stay with them for the first 15 minutes to make sure there's no reaction?
Correct. And can you run blood alone, or do you have to piggyback it into something else?
You piggyback.
Right. So you're using a Y line. And I'm not sure if you guys ever saw that. Have you guys seen the Y lines for blood? Okay. So you're going to use that. So if there is a blood reaction, what is the number one thing you're going to do for a blood reaction?
Stop the I'm having a brain fart. Stop the administration. Stop the IV.
You got it. Very good. All right. And then obviously if none of this is not effective, then we need to get mom to the OR. Okay.
And what is it? Is it usually piggybacked with normal saline?
Yes. Yes.
I was thinking stop infusion. That's
yeah.
That's
okay. Trust me. This is like the third day of teaching this, so if I get a little loopy. All right. So that was pretty much the end of postpartum hemorrhage. Does everybody have a good understanding of what's going on, what's causing it, and how we're treating it and managing it? All right, so then the rest of the focus is just basically going to be on the newborn. And I'm going to talk about normal. So everything with the newborn, if you know normal, then anything anything off there. I'm not going to get into any of the neonate emergencies. All that's going to be in exam 3. So no respiratory distress or anything. This is just basically your normal newborn assessment. And unfortunately, a lot of this stuff that we're talking about today is stuff that I did in simulation. And it was always really nice because I could really make sure the students had a good understanding of it when I would grow them into the sim lab. So I'm just going to have to do the best I can with videos and have you watch videos and have you do different things. And hopefully I can get some of this stuff into you in that regard. So the next one is chapter 15. So we're going to talk about the physiological and the behavioral responses of the newborn. This looks like a lot of information, and let me just kind of tell you, I'm going to give you the skinny on this slide. I'm going to give you the skinny on a lot of these slides, okay? So basically in this slide, where I want you to focus on is the baby is basically going from intrauterine life to extrauterine life. So when the baby's in intrauterine life, what are they breathing? What are their lungs breathing?
Amniotic fluid.
Very good. So they're breathing amniotic fluid. And as they were going through the birthing process, the mother's contractions are squeezing the fluid out of the baby's lungs as they're going through the birth canal and coming out into the extrauterine life. And so when they are born, obviously all those changes are occurring. The lungs are now going to be air, utilizing air, not fluid. And then the baby is born. And what we want to see is the baby takes that deep breath, starts crying, and that exchange happens. And that baby goes completely breathing air. Sometimes a baby born and they come out and they're not crying right away. They're not, they're full of fluid and they have to, they have to take a bulb syringe and clean out their mouth and nose. Absolutely. And as a matter of fact, that is one of the first things that you're going to see. Has anybody seen a delivery? Okay.
Yes.
Sylvia, when the baby was born, what was the very first thing they did when the head started to come out? Do you remember?
They, I don't remember. Stacy was there with me. They turned the baby upside down or something like that. I don't remember.
Right. So what they want to do is they want to get that airway cleared of any fluid. And so basically our number one thing when the baby's first born is making sure the baby's breathing.
Yeah, I think they suction before the baby's even fully out of the mom.
Exactly. A lot of times, as soon as the head comes out, you'll see them suctioning the nose and the mouth out. So just keep that in mind. That's pretty much what I want you guys thinking on this slide is we want to make sure that that baby's breathing. So that baby's going to go from breathing in amniotic fluid to coming into the world and breathing air. So our number one thing when the baby's born is making sure that they have good working lungs, right? We want to make sure they're crying, we want them crying and we want them working those lungs. So that's pretty much what that slide is that's what I want you to get out of that. So I put here some signs of fetal respiratory distress. I'm not really going to go into a lot of respiratory distress in this module. I'm going to wait until module 3, but just to kind of give you a little heads up on some things that would be abnormal. So if the baby was cyanotic, meaning the baby was really blue, if the baby had difficult time breathing, had a lot of periods of apnea and some tachypnea, if you see some retractions, and some of these things you'll see like the retractions of the chest wall, you can see in your COPDers, some grunting or flaring of the nostrils, and kind of limp, kind of a low tone. They would be some signs of respiratory distress. Sometimes babies have apnea, periods of apnea, and that's normal, providing that they're eating, drinking, peeing, pooping, they're pink, they're not, their nasals aren't flaring, they're not having any chest retractions, and they're very active. That's just normal. I don't know if you ever watched a baby, when a baby's sleeping, they can scare you sometimes. So you're looking at them and it's like, all right, are they breathing? I had a student this morning who was saying she was having a really hard time trying to assess respirations on a newborn. She was, it's so hard to see if they're breathing, and especially too when they're all bundled up in blankets, right? But that's just some signs. And again, we're going to address more of that in 2 weeks from now. So circulatory system, basically the same thing. Everything is shifting from a fetal circulatory system to a neonatal circulatory system. And that whole thing is changing. The heart and the lungs are all changing as the baby is being born. I have a little video for you. This is about maybe 3 minutes. And this doctor does a really nice job of explaining how that whole process is happening.
So a question that I often get asked, even by fathers after a baby is born, is how the baby has gone from breathing the amniotic fluid of pregnancy to breathing room air, and how that process occurs. It's a very complicated process that initially involves blood vessels in a baby when the baby is in utero that we don't have as adults. But the simpler part of the process comes in the actual labor process. So when a baby is inside a mother's womb, there are extra blood vessels that keep the baby from needing lungs the way that we need lungs to process oxygen. So in the womb, the baby actually doesn't use its lungs almost at all. And so they're full of fluid. That fluid keeps pressure on the blood vessels of the baby's lungs so that they don't open and they aren't needed. When the baby is going through labor, the natural compressive forces on the baby in the pelvis and with each contraction actually push that fluid out of the lungs with every contraction. And over time, what happens is as there's less and less fluid, the blood vessels in the lungs open gradually because there's less pressure on them. As that happens, they start to recognize more and more oxygen from the fetal blood supply, and they get even bigger over the entire labor process, as those vessels become larger and larger and start retaining more oxygen, one of the extra blood vessels that babies have starts to close. And that's one of the blood vessels that keeps the blood from going to the lungs while the baby is inside of the mother's womb. So as that blood vessel closes and there's less pressure on those vessels in the lungs, the air starts to go preferentially to the lungs instead of just the circulation that the baby has already had. When the baby is finally born and the fetal head is delivered, the baby starts to take those breaths by response to the lack of oxygen that it's experiencing. And those initial breaths bring even more air into these blood vessels in the lungs that are opening and allow those blood vessels to become as wide open as possible. Once those vessels are open and that other blood vessel has closed, the baby will breathe exclusively through its lungs. Sometimes what parents notice is that a baby is coughing or spitting after delivery or has a difficult time transitioning to breathing. And that's often because the baby hasn't squeezed all of the fluid that was in its lungs when it was in utero out to breathe air. And that can cause babies to have what we call transient tachypnea of the newborn, which is retained fluid in the lungs, which leads to difficulty breathing, sometimes taking shallow, short breaths instead of good, deep breaths, and sometimes difficulty sleeping. So some of those babies will need to have extra care or extra suctioning to get some of that fluid out. You'll also notice that the nurses in the delivery room really want to make your baby scream. And that's because that screaming and crying helps bring even more oxygen into those developing lungs and clear out the rest of that fluid.
Any questions on that? Sorry. All right. Are you guys good? Is everybody good with me? Okay. Okay, so the next thing we're going to talk about is the thermoregulation system. What do you think the thermoregulation system is? What do you think its job is? Carol?
To keep the baby's temperature regulated?
Absolutely, correct. So the thermoregulation system for the newborns is immature. So it doesn't work really well, but the baby has some fat stores that are designed and they're there when the baby's born, and they'll kind of go away after about a month or so of the newborn to kind of help with those. Does anybody know what they're called? They're called brown adipose tissue or brown fat. You might have heard it as brown fat. So some of the things that we want to do is make sure that the baby doesn't lose a lot of body heat. So what are some of the things that we're going to do as nurses to intervene and make sure that that baby maintains their temperature?
Keep them swaddled.
Right, swaddled. Carol?
Under light?
Good. So put the baby under the radiant heat warmer. Jess?
Dry them off immediately after birth.
Good. And when you dry them off right after birth, these are things I did in my simulation. What would you do with that bath towel that you just dried the baby off with after they were born? This is super, it's so easy, you probably don't realize it.
Get a new one.
You got it. Yeah, that's all you do. So, it's so easy. It was one of those ones like, is this a trick question? No. So when you dry the baby off, you get rid of that one, and then you swaddle the baby with a new towel. That was one of the things I looked for when the students were doing that sim. Did we say hat? Did we say put a hat on the baby? Okay, so make sure you put a hat on. Skin to skin, so have the baby, and not just skin to skin to mom, you can do skin to skin to dad or significant other as well. So you put the baby on the chest, chest to chest, and then like put the blanket around, the baby. We talked about the radiant warmers. Another thing is when you're going to listen to their heart, lungs, and all that stuff is warm up your stethoscope. I'm sure you guys probably do that already when you're doing your assessments. Nothing worse than somebody coming up to you with a really cold stethoscope and going to like listen to your heart or lungs or your belly. It kind of like makes you jump. So make sure you warm up any of your equipment. Make sure anything that you're using, like if the baby's getting formula or, well, be formula because breast milk is different, but you want to make sure that things are a little bit warmer than room temperature. I know one of the students in the morning class said, well, a lot of the times the little cribettes come and they have like a drawer and they have the formula right in there, and that's kind of room temperature, but you want to really make sure it's a little bit warmer, and especially if they're, like you think about if anyone was in the NICU, when they're in the NICU, they have them in the warmers, and because they're getting, a lot of times they're getting fed by NG tubes. So we want to make sure, because anything that goes into them, if it's cool and they're very sensitive because they don't have a lot of fat to keep them warm, that's going to chill them very quickly. Think about if we're out on a really hot day and we're playing and we come in and we go and get a big, a big slushy or something. I'm going to think of 7-Eleven when I was a kid. You go to 7-Eleven, you get this big slushy, and you start drinking it. It's going to cool you down right away. Or if you're really cold and you go get a cup of hot chocolate or hot tea or hot coffee, and you kind of hold that mug like, tea like this, and you get the heat from that. So you want to just make sure that everything is warmed for the baby. Another thing they do is they delay the bathing. So it used to be they bathe the baby right away, but now they delay the bathing so that it lets the baby kind of get accustomed to being in this new world. There's that adipose tissue or the adipose fat. So the babies can't shiver. So this is their way of making heat. And so the baby will have this adipose tissue. It'll be like kind of around some of their vital organs. So they'll have it on their chest, underneath their axilla, around their kidneys and adrenal glands, and on their scapula in the back. And there's a picture of it. If you can look on the bottom there on the right, I have a picture of the adipose tissue on the baby. Some things that would that are affecting their thermoregulation. Most babies already have a decreased amount of subcutaneous fat. And then think about those premature babies. Has anybody been to the NICU? So Mindy, you were at the NICU. Did you notice how you can see some of those NICU babies? I don't know if you're with some of the really small ones, but you can actually see some of their veins and stuff like that because their skin is so thin and translucent.
Yeah.
So they don't have a lot of, they don't have a lot of fat to keep them warm. Also think about your large for gestational babies. So there's a lot of surface area. So you want to just really make sure that you're maintaining body temperature. So this basically, it says at the bottom that cold stress can be fatal. And I'll explain this to you, but we're going to talk a lot more about it in 2 weeks. So the baby can't maintain their temperature. They're really cold. And so they're going to start trying to burn more calories, use up more energy to try to get warm. So when they start using up more energy, what's going to happen to their blood sugar? They're burning up a lot of calories and
It drop.
Right, so their blood sugar is going to start dropping. Now, a baby's blood sugar is not critical until it's less than 40, whereas an adult, where are we starting to worry about our adult population?
Is it under 70?
Right. So our adults are under 70. Just think our newborns are about 15 milligrams per deciliter lower than our adults. So we're okay until about 40. So the baby's really cold, can't maintain their body temperature. They're working harder to try to get warm. So that working harder is going to drop their blood sugar. And then they're working harder, so they're going to be breathing. They're going to be breathing faster, and that's going to increase their oxygen demand. And so initially they're going to be working harder, they're going to be breathing harder, and eventually they're going to start going into respiratory distress. So it's kind of this poor cyclic event that's happening. And then the respiratory distress, the hard breathing, is going to make them work harder and put them in more stress. It's going to drop their sugar more. They're going to be working hard. They're not going to be able to maintain their temperature. They're going to get colder. So you see how that just kind of, we need to break that cycle and intervene. So we want to get them warm, get them something, get food into them. If the baby's blood sugar starts dropping, what do you think how would you intervene, or what would you have the mom do to intervene if the baby's blood sugar starts to drop?
Breastfeed.
Right. So it used to be, Carol, did you have a question, or do you want to say it too?
Yeah, I was going to say that.
So it used to be, back in the day, I know when my one daughter was very large for gestational age and she had low blood sugar when she was born, they used to give sugar water. Well, now the first line of treatment when their sugars are starting to drop is to try to get mom to nurse them or give them a bottle. And then if that doesn't work, then you're giving them the sugar water or the glucose IV or however they need to get it in. So think about our adult population. We go in and we see our adult population, same thing. If somebody's a little bit low, but they're alert and oriented, what are we going to be giving them?
Juice.
Right, just giving them some kind of quick acting sugar, right? So we're going to be feeding them. And then if either they're not alert and oriented, or we've done that, we've rechecked them and they're still low, then then we're going to be giving them the either IV glucose or something like that. So same thing, and I think I have it on my next slide here. Let me just go. There it is. Okay, it's not. I'll go back, but just to show you here. So here is their blood sugar is low. On the left side, it gives you kind of the risk factors. So reasons why a baby would have low blood sugar: be large for gestational age, post-term, hypothermia, respiratory distress. So the treatment initially on the far right-hand side would be the breastfeed or formula feed. If that doesn't work, then giving them the dextrose, either IV or buccal, or however you need to get that into them and maintain their temperature. And let me jump back. Oops, where's my thing? Okay. Any questions on that? This is signs of cold stress. And again, we're going to go into this in a lot more detail, but I just want to just kind of talk a little bit about it. So some signs of cold stress would be cool to the touch. So the baby's cool to the touch, has low blood sugar, kind of, grunty breathing, lethargic, and a temperature of less than 97.7. That would be your key, your 97.7. I think we talked about all of this, nursing care management. Yeah, everybody okay with that? Okay, and we talked about the blood sugar. Are you guys good with the blood sugar? All right, the next one we're going to talk about, the focus here is on the jaundice and on the bilirubin. So when you think about the iron storage and the red blood cells, as long as mom is good, as long as mom had a good store of iron, the baby should be good for about the first half of their life. So as long as she's good, they should be good. But what we're worried about is, because a lot of the baby systems are immature, the baby's liver needs to get rid of this bilirubin. So they have their red blood cells are being destroyed very rapidly, and the way that the bilirubin is excreted is through their stool. So they need to be getting this out, and one of the first things you'll see with the baby is, like, for the first day or so, they might be a little bit jaundiced. And where do you think you would see the jaundice initially in a baby?
Is it their eyes or is it just their skin?
Yeah, well, actually both. So you would see their eyes first, but then it would progressively go, to their skin, and mainly in the face. That was Jenna, right? Yep.
Yes,
So you
yes.
see it in their eyes, in the sclera of their eyes. You may start seeing it in their face, and then if it progresses, it would start going down to the trunk and the lower extremities. So again, it's going to peak initially. A lot of times babies might peak, and then they may be sent home, but they may be sent home with follow-up with the doc, so they're going to have to go back and get that heel stick and be rechecked, and they may need like a Billy blanket, or they may just say, like back in my day, they would just say take him outside in the sun, or put him, sit near a window and stuff like that. And the sun is going to help break that down. So assessing it down the bottom here, you're going to check the eyes, the skin, and then if it progresses, you'd see it more in the face and down to the trunk. All right, good. Are you guys doing okay? You guys good with me? Okay. This doctor's going to kind of go over the jaundice, checking this baby for jaundice.
Shortly after a baby is born, its skin may appear a bit yellow. This is known as jaundice.
Jaundice in newborn babies is really a normal finding. And the most common cause of jaundice in newborn baby is what we call physiological jaundice, which is just a process of adaptation that baby's making to life outside the womb.
Ryan is checking over Maria Vittorio's baby, Tamami, who has low blood sugar levels. She's also a little jaundiced, although so far her jaundice levels are low and they don't need any further treatment.
When a baby's born, it's born with a lot of hemoglobin, which makes your blood red. And over the first few days of life, your hemoglobin level drops slowly, releasing hemoglobin, which then has to be metabolized. And a product of that is bilirubin, which makes your skin appear yellow.
I see.
For the vast majority of babies, jaundice is not dangerous and does not usually require any treatment. The jaundice first appears in the face and then creeps down the body. And if you look very closely, you can tell a baby's jaundice by looking in the whites of the eyes. You can see that they're yellow.
Yeah.
And if you press the nose,
You mean in the white?
Yes.
Okay.
Babies typically do get some blood tests if they're detected to be jaundiced. We will look for evidence of conditions that might make the jaundice worse and therefore require treatment. Babies who present with jaundice in the first 24 hours and who are likely to become severely jaundiced is usually because of an incompatibility between the mother's blood group and the baby's blood group. For example, if the mother's an O group, she might develop anti-A antibodies to her baby if the baby has A group blood.
In extreme cases of jaundice, effective treatments are available to rectify the problem.
If a baby becomes significantly jaundiced, it will usually require phototherapy, which is a simple treatment where we lay the baby under a special light, which is at the extreme end of the blue light spectrum, which converts the yellow pigment in the skin to a different substance which can then be excreted in the baby's urine.
I think that escape.
Okay, Anna Winter?
I'm working on this, guys. Oh, there we go. Why won't that stop? All right, any questions with that? I'm sorry. My husband pulled in, so once he gets in, he's going to take them somewhere. Somewhere far, far away. So basically, you want to encourage mom to nurse and feed the baby because that's going to help excrete that bilirubin. And if that level doesn't go down, then they're going to be treating the baby, putting the baby under the lights. So maybe put the baby under the lights while they're in the hospital, or they may send the baby home with a billy blanket. I think there, and there's has anybody seen the billy blankets before? Some saying yes, some saying no. Oh, good, you're home. They're yapping. You can take care of them. Sometimes moms will think that if you say that the jaundice is related to breastfeeding, they think that the breastfeeding is causing the jaundice. And it's not that the breastfeeding is causing the jaundice, but maybe the mom is not breastfeeding effectively and the baby's not getting enough milk. So that's where the term breastfeeding jaundice comes from. But just let mom know that it's not caused by the breastfeeding, but maybe caused by poor feeding practices. So just let the mom know that they usually will resolve in a couple of days, and just to keep feeding the baby and making sure the baby is voiding and making sure the baby is having stools, and that's going to help clear the bilirubin and bring the bilirubin levels down. Next thing I want to talk about is coagulation. So the baby has a immature ability to clot their blood, so they need to have vitamin K. Vitamin K is given within the first hour. Has anybody given a vitamin K shot? Okay, good. On this clinical or in your PN program?
It was for this clinical over at Pocono, Lehigh Valley Pocono with Michelle Cohen.
Oh, good, very good. So what muscle, and anybody can help Sylvia out, what muscle are we giving the vitamin K shot in?
Vastus lateralis.
Correct. So it's an IM shot. You're giving it in the vastus lateralis. It's given within the first hour to help the baby clot their blood. Some parents are a little funny about any type of needles because they think that everything's an immunization. And just explain to the parents this is not an immunization. This is needed. Babies can actually die. They can bleed out. Not every single baby, but we don't know. We don't want to say, okay, this baby will, this baby won't. We can't decide which one would and which one wouldn't. There's been cases where there's twins where one did and one didn't. So, I mean, not that they bled out and they die, but they can, and it can be fatal to the baby. So we want to make sure that the parents understand that. A couple of important things I want you to know about vitamin K. So I want you to understand that it's used to help the baby with clotting of their blood. It is given within an hour of birth. It's an IM injection, and the needle is going to be, you're going to use a 25 gauge, 5/8 inch needle, and it's going in the vastus lateralis in the baby. Any questions on that? I do have an article I want you guys to read. I don't know if you got a chance, if anybody had a chance to read the article yet, but under module 2, I have an article about best practices for giving a newborn injection. So please make sure you read it. There's about 15 questions that goes with it. And then just upload the questions. You just have to write 1A, 2B. Don't write out the questions. You have enough work to do. If we were face to face, I would have given you a Scantron to have you do that. But there is going to be a question or two on the exam from that. So please make sure you go back and read through that. So this is just the process that you would do. So the first thing you would do is clean the site with alcohol, have everything ready, get all your supplies ready, and make sure you have the right needle size and gauge and needle size. And then when you're giving the IM, remember you're going to make the skin taut. So you want to, I'm just using my arm because my leg's down here, but make the skin taut. And then you're going to give it in like almost kind of like a dart fashion. It's going to be 90 degrees. And when you give it in the vastus lateralis, you want to do like maybe about like the lower third. And I have a picture of it to show you of the vastus lateralis, because you don't want to get anywhere up by the sciatica, by the sciatic nerve. And I'll show you in a second. Some of your parents might ask you if they could have the oral vitamin K versus the IM. And there's been a lot of studies done. As a matter of fact, I asked the one director at Pocono, and they don't even carry the oral because they said that it's really not very well absorbed. And it kind of works kind of like a placebo effect. So it's not really effective, and it doesn't really do what it needs to be done, it needs to do. So here is the picture. Can you see my mouse when I move it around? Okay, so here is your vastus lateralis muscle. So again, if you want to go into the lower portion of it, because up here you have your sciatic nerve, you have here's your greater trochanter. So you want to go more of this section. It's kind of hard to tell on here, but it's going to be more on your lower section there. And then this is just a little video. This video at the end. At the end of the video, she actually wipes the site with alcohol. I would go by protocol of your hospital. So I've seen done several different ways. I've seen some where they just put a Band-Aid over after they gave the injection. I've seen some where they didn't use a Band-Aid, they just put like a 2x2 there and just held it for pressure. And in this video, she says, to wipe it, but I'm not going to be, testing you on what you're supposed to be doing after, but just to give you an idea.
Medication administration to our infant. You need to make sure you have your supplies ready before you begin. You need an alcohol swab. You need a syringe with your sucrose water for pain management. And you need your syringe for your medication administration. For an IM injection to a newborn infant, we need a 1 ml or 3 ml syringe with a needle that is 5/8 25 gauge. We are going to have our infant in our crib. We're going to check our identifying information against our baby's flow sheet and medical record. We're then going to prepare our medication and draw up our glucose sugar.
And what's the purpose of the glucose sugar?
It distracts them.
What's that?
It distracts them from the pain.
Right. So they use it as like a non-pharmacological pain and pain medication, so to speak. They'll also, Sylvia, when you did yours, did they have you give any sucrose or not?
No, she didn't.
Okay.
Once we are ready to begin, we need to do this single-handedly. To hold your baby's leg, you are going to take your lower 2 fingers on the baby's lower half of their leg. Your middle finger is going to lay across the top of the baby's thigh with your thumb and your forefinger. Your forefinger lies next to your middle finger and your thumb down below. And this is the area that we are shooting for. We want to make sure that we keep our baby's leg bent, so we keep the muscle relaxed, so we cause the least amount of pain and the most medication absorption possible. If you have someone with you, you can then ask them to administer the glucose water to your sugar water to your baby. If not, you would do it before you maintained your hand grasp. This hand does not move once it is in position. You then alcohol your area. You remove the cap from your syringe with your thumb with 1 movement. You are going to inject perpendicular to your injection site. It is quick in, then slow.
So I'm just going to pause there. So you see how it's kind of a little bit down to the lower part there of the vastus lateralis muscle. So see how she's about halfway, like here, up here would be your trochanter, and then she's right about there, just to show you.
Slowly with the medicine. Once you've injected all of your medication, you count to 3. You withdraw quickly. You put your safety up, and then you then apply alcohol to your site before letting go of your leg. We do not aspirate on any baby immunizations, and we console the baby directly afterwards. So we would then wrap the baby up, pick the baby up, and hold the baby.
You guys got the idea. Any questions on that? Are you guys good? Okay. I'll just kind of pause like every 15, 20 minutes to see if you need a break. If you need one beforehand, just say, hey, you know what? But if you just need to step away and go get a drink, go to the bathroom real quick, go for it. I mean, it is being recorded. So if you need anything, don't hesitate to go do whatever, whatever you need to do. I just wanted to show you, bring this to your attention. So a couple of things with the GI. So the baby has a very small stomach. So when moms are feeding the baby, you want to let them know in those first couple of days, the baby's stomach is very small. So a little bit is okay. They're, especially if they're breastfeeding. Breastfeeding moms just get like, oh my God, I don't know if I have enough milk. But if you just kind of explain to them, the baby's stomach is very small, and as they get older, they're gonna need more. And just make sure that if they're bottle feeding, they burp the baby, and just kind of, let them know that the baby stomach is very sensitive, and depending on if she's nursing and she's eating certain foods, it can be very, cause a lot of colic and stuff with the baby. Elimination. So their first stool is meconium. And what color is their first stool like? You remember?
Black.
Yep, so it's black. And then after that, it's going to start transitioning. So it might be yellowish green, or in change for a breastfed baby. And for a formula-fed baby, it might be a little more liquidy more frequently. Generally speaking, they should have anywhere from 2 to 3 stools a day, and maybe even more frequently, just depends. And they're kind of looking to eyeball about 6 to 8 wet diapers a day. And that's kind of what you want to aim for. And there's just some pictures there. Doesn't that look good? So it kind of shows you the meconium here in the beginning, and then that transitional stool from the breastfed baby. And that just kind of gives you a different, so day 1, day 2, and just how it changes. So the kidneys, hopefully by 48 hours, the baby has voided. They're not, generally speaking, the baby's going to void, initially right away. It's pretty common for the baby, as soon as the baby's born and they put the baby under the heat lights, and they're starting to do the baby's assessment, and the baby starts peeing. But many will void right after birth, about 93% by 24 hours and 100% by 48 hours. Immune system, again, just like ours, the baby still has some of mom's immune system and has a lot of antibodies from mom. And if mom is breastfeeding, the baby gets a lot of that from mom. And the one immunization that we give to the babies about a day after they're born is hepatitis B. Did anybody give any hepatitis B shots? Sylvia, you did that one too?
I forget which one I did. It might have been this one, or it might have been the vitamin K, but we gave both of them right after, because it was a C-section and the mom was Hep B positive or something like that. So we gave those right away, and then we gave the erythromycin in the eyes as well.
Perfect. That's another one I'm going to be talking about in a few minutes. All right, any questions so far? So this is just a flow sheet that kind of goes over some of the key things that you would be doing for your newborn assessment. So the newborn assessment is going to be done 3 times. It's going to be done right at birth. They'll do the whole assessment. They'll do the assessment on the nursery, in the newborn nursery, and then the physician has to do a full assessment before the baby's discharged. And these are just the key areas that are looking at everything. And that's just what I was talking about there. This is the video. I gave you guys the link under your module 2. If you would watch this video, it's about 30, 35 minutes long, but has anybody watched it already? Okay, so Sylvia, so it really goes through the whole thing. It's very thorough. So when you're watching it, if you haven't watched it yet, you want to kind of look at, these are the different key points that they're going to be talking about. So they're going to kind of go through the general appearance. What and we're looking at normal. So what, what does the baby look like overall? So you're kind of looking at the whole picture. And then you want to start doing the measurements. And what are the key areas that we're measuring? What are some measurements we're doing with the baby? Mindy or Sylvia?
Isn't it like head, torso, overall length?
Right. So we want to measure the head. We want to measure the chest. We want to measure how long the baby is, how much the baby weighs. We want to do our vital signs. We want to get a full set of vital signs. The next one I have is the skin characteristics, which we will talk about in a minute. I'll go through all of those. It's actually on your CLG number 5, so you won't get to that. Maybe a few of you have. I'm just going to get to the page here where that's at, so I can kind of go over that with you. And if you're looking at when you're doing your studying and you're looking at that video, if you kind of put on in your notes page 452, they start going over the newborn assessment. It kind of talks about everything they're looking at. So they're looking at the head circumference, the chest circumference, the length, the weight. They're your measurements that they're looking at. And then they're looking at symmetry. Is everything equal from one side to the other? Is everything patent? So they're checking to make sure. They're checking to make sure that the baby has all the normal reflexes, which we're going to be talking about in a few minutes. They're looking at skin color. They're looking at breathing. They're checking the heart. They're checking the genitals. All the extremities. So they're going through this whole thing with the baby. So this is a list of terms, and this actually comes from your CLG number 5. So if you've done your CLG number 5, this will sound very familiar. If you were going through your textbook and reading your chapters and stuff like that, when you're looking at chapter 15, they go over all of these. And I'll give you the page number in a second. I think it's 460. Yeah, so if you have the 3rd edition, these terms will start on page 460. And I'm going to kind of go over some of the key ones that I want you to know. But most of them you're going to know already. So, like, what's vernix caseosa? Carol.
It's the whitish covering over the skin when they're born.
Very good. Meconium. Carol. Oh, you're muted, Carol.
The first bowel movement.
Very good. Cold stress. What did we say cold stress was?
They're unable to keep their thermoregulation, their temperature up.
Correct.
And they drop with their blood sugar.
Right. So cold stress basically means they have low body temperature. That's just a fancy name, or maybe not so fancy name. And then what was the brown fat I was talking about? It goes with the thermoregulation. In your own words, doesn't have to be. Carol?
It gives them the heat, like deposits heat.
Right. So it's these fatty deposits that are on their around their chest, around their thorax. It's between their scapula, underneath their armpits, and in their adrenal and kidney areas, and it's going to help with the heat regulation. When you think of circummal, and I have all the definitions in another slide in a minute, but if you think of circummal cyanosis, you think of blue lips. So circummal means around. So it's that's one of their first signs that they're having respiratory distress. Is they have that circummal cyanosis. A lot of times you see that if you think about when we were kids, or when your kids or your nieces or nephew are in the pool for a really long time and starting to get cold, and they get a little bit of those blue lips because they're just so cold, they don't want to come out of the pool. All right, hypoglycemia should be fine. Fontanelles. Don't worry about gestational age assessment. I actually took that out of my slides, so don't worry about that. Acrocyanosis. What does acrocyanosis mean? Mindy's trying to say it, but I think you're muted, Mindy. I'm not saying that. Carol?
Is it like blueness in their hands?
Correct. So their torso is pink and their arms and legs are blue. So that when you're doing an APGAR score, that would give you a 1. So if in your description, if they said the baby had acrocyanosis, that would give you a 1, versus if the baby was completely blue, that would be a 0. And if the baby is completely pink, that would give you a 2. Let me see. Hypothermia, I think. Lanugo, what's your lanugo? Jessica?
The fine downy hairs on the baby.
Very good. Molding. When we say molding, what are we talking about? So think about when the baby is being born. And remember their fontanelles. Go ahead.
Is it the overlapping of the bones when they're being born?
Right. So it's the overlapping. And then they kind of take on kind of like a cone shaped. Very good. So there are some of the easy ones, and I'm going to go over the ones that I really want you to know also. So the first one that you might not be real sure about is called milia. It's the 4th one down. And milia, you'll see for the first couple of days, not every baby will have it, but they're like these white papules. They almost kind of look like little pimples on their face. And milia is the white ones. We're going to talk about another one, but the milia ones are white. They disappear. They don't mean anything. I mean, they might be from oil glands or sebaceous glands, but they're actually on your textbook. They have them on page 460. They have a picture of the milia, and just tell the parents that they usually disappear in a couple of days, couple of weeks. The next one at the bottom is Mongolian spots. And your Mongolian spots, a lot of times you'll see that on the coccyx or on the back side, and they kind of might resemble like a black and blue mark, and it's just areas of bluish black pigmentation on the dorsal area of the buttocks. And they have that also. It's they have a picture of that in your text on page 460 as well, of the Mongolian spots. And what else do I want to talk about? Okay, the next one. So we talked over here about the milia, and we said the milia was tiny white papules. And then on this side, we're talking about erythema toxicum. And erythema toxicum is also a rash, and this rash is more pink. So the milia is more white and the erythema is more pink. And again, really no known cause, and just how they may disappear in about 2 to 3 days. The next one is Epstein-Pearl. And Epstein-Pearl is in your textbook. There's a picture of that on page 462. And they're like these white pearl-like cysts that are on the gum line inside. Jessica, you had a question?
Yeah, where is the erythema toxicum located on the baby? Is that face?
That could be face, and I think it can be some of their extremities as well. Let me just see who said that. It just says different areas of the baby, of the body, and also in the trunk area. And Carol.
Are we, on the exam, are we going to have to match these up by a picture or anything like that?
Oh, no pictures. No pictures.
Okay. All right.
That would be a little difficult, but there's no, I don't think there's any matching. I don't think I have matching on this one.
Okay.
No, because I think it's too hard to tell, these in pictures, but I'm showing you the pictures just so that you can kind of have a visual. And then I told you about Epstein-Pearl, right? That's the white patches along the gum. I think I got everything else we talked about. So let me just kind of go back. I mean, the other ones we know, but The ones that you might not be familiar with would be the milia, the Mongolian spots, the erythema toxicum, and the Epstein's pearls. All right, this next one, the reflexes are pretty easy. There's two that might be, a little more tricky, but the reflexes are described on page 463 of your textbook to 464 of your textbook. And we'll go over these. So the first one is tonic neck. And so when you think about tonic neck, think about the neck. So they're turning the head to one side, and in response, the extremity of that same side. So right now I have my head turning to the right, and the extremity of that same side is straightening, and the opposite side is flexing. So that's tonic neck, and that'll be present till about the 3rd month. And you might have seen some of these when they were doing the initial newborn assessment, but sometimes they go through them so quickly they don't realize they're doing them. The next one's the grasping. I think that's kind of self-explanatory. So you put your hand out, and the baby will wrap their fingers around your hand. It's kind of, a lot of times people think it's really cute, like, oh, the baby's holding on to me, and that's actually a reflex that the baby has. The next one is the scaring one, or the startle one. So this is, the baby will elicit, like, its hands and legs will kind of go out like this, like it's startled or it's scared. You can elicit that by either making a really loud clap or really loud noise. Some nurses will hold the baby and just kind of like lower it a little bit, like they're lowering it into the crib, and that sudden drop like that, you'll see the baby kind of put its hands out like this. And that will persist until about 6 months. The next one is the rooting. And so if you touch the baby like on the right side, the baby will kind of root over and try to go towards the food or towards the breast or the nipple of the bottle. And you touch on the left cheek, and it'll go over to the left side. And then the sucking one, the nurse would put a clean gloved hand in the baby's mouth, and then the baby would be sucking on the finger just like it would if it was sucking on the breast to nurse, or if it was sucking on the nipple of a bottle. This one's a little weird to remember, but it's called trunk incurvation. And so basically you have the baby in the prone position, so the baby's laying on their belly, and then you take your hand and you trace down the baby's spine. And if you trace, like you see they're doing it on the left side of the baby, they're tracing like kind of like a curve like this along from the left shoulder down to the left buttocks. And then you see that the pelvis, it causes the pelvis to turn to the stimulated side. And then if they did this on the right side, if they went from the right part of the shoulder down to the right buttocks, it would bring the right, it would cause the pelvis to turn to the right side. And that's called trunk incurvation, because they're causing that to curve to the one side. And then this next one is the Babinski. And so basically what you're doing is you're eliciting you're going and taking your finger and you're going across the sole of the foot, and it takes the toes from like this and they spread out, or they fan out like this. And what do you think the Babinski would be very useful in doing? Like you need to get a birth certificate around, you need to get stuff. What do you think that'd be a really good reflex to obtain something? Jess?
Their footprint?
Yeah, because if their toes are curled in like this, you're not going to get a good footprint. But if you go like this and you span them out and you put the ink and you get their footprint, you're going to get a really nice footprint on that baby, right? And then the next one is stepping. And so a lot of times people are like, oh, my baby's so smart. Look, he's already trying to walk. But it's actually a reflex. If you hold the baby and you put the baby's feet on a flat surface, the baby will kind of have like a stepping motion like this. And that lasts up to about 1 month. Any questions on any of those reflexes? This one here, we're going to talk more about maintaining airway. But remember I said one of the most important things you're going to do as a nurse in the labor and delivery when the baby's, as soon as the baby's head starts to be delivered, is what do we want to be concerned about? Jess or Carol?
Airway.
Airway, right. So we want to maintain airway. And a couple of things I want you to know on this slide is your vital signs. So I want you to know the normal temperature is 97.5 to 99. Your normal respirations are 30 to 60. And your normal pulse is 110 to 160. And you're going to also need that if you're going to be doing your ABGAR, right? So you're going to be looking at your ABGAR, you're going to be measuring your heart rate and stuff. Don't generally do a blood pressure on the postpartum unit. You may see that being done though in the NICU. So if you were in the NICU, you probably saw them getting their blood pressures done. And so I kind of put it here, but I'm not expecting you to be able to tell me what the normal blood pressure is, but generally about 60 to 80 systolically and 40 to 50 diastolically. Did anybody see them do the blood pressures on the NICU? No. We talked about this. I don't think there's anything different. Are you guys good on how to maintain a neutral thermal environment for the baby? Okay, eye infection. I think Sylvia was talking about this. So she said she did the 2 injections and she did the erythromycin eye ointment. Is the medication that is pretty much standard across all of our states, and it's used as a prophylactic for gonorrhea. And so you're going to put the medication in the lower conjunctival sac of each eye. You can wait about an hour to do this. Why would we say it's okay to wait about an hour? What do you think it can interfere with if we did it right away? Jess?
The skin to skin?
Right, because and just think if we put something really like Vaseline or something blurry near our eyes, it could cause, it could, blur our vision. So sometimes I'll say, let's wait about an hour and let mom and baby bond so the baby can kind of, start focusing on mom. So about an hour or so you want to do that, but they can have some skin to skin. So basically you're going to be doing the vitamin K within an hour, the erythromycin. Jessica, tell her I said hi. The erythromycin, and the hepatitis are the 3 medications. Skin integrity. So you want to keep, basically you don't have to bathe the baby every single day, but you want to get all those key areas. So if the baby's soiled, obviously you want to be cleaning the baby, but you want to be keeping that umbilical cord clean and dry. Just if you do need to clean it off, if it does get soiled, just use some sterile water and air dry it. You want to fold the diaper over. And basically the key thing is watching for any signs of infection and teaching your parents when they go home to observe for any foul smelling odor, green discharge, yellow-green discharge, redness, or of any signs of infection. And just tell mom and dad that they'll fall off in a couple of days. Usually within a week, the umbilical cord will fall off on its own. Safety. So what are some key important things that we want to teach the parents about safety in the hospital with their baby? Jess?
If they're tired, make sure that the baby isn't kept in the bed with them so they don't fall asleep with the baby in bed.
Mm-hmm. Good. And also, I don't know if you guys saw those, there's been a bunch of stuff out in the literature now about babies being dropped. So you want to make sure that if she's real groggy, if she had medication, if she took something, maybe she took, she had an episiotomy or some lacerations, we gave her a little bit of Darvocet, just like, hey, just make sure you say, let us know. We'll take the baby and put the baby in the bassinet. Mindy?
Back to sleep.
Good. Back to sleep. What about being concerned about people coming into the room that you don't know who they are? So you want to make sure you educate the parents that anyone who comes in, if they're suspicious or don't feel comfortable with that person, let them know. Don't just hand their baby over to anyone. And all personnel should be coming in. They should have their IDs, and they should be also checking everything. And if they're bringing the baby back, they want to make sure that the mom and baby both match. And they have the security bracelets now for the baby, that if the baby does go off the floor, it sets off an alarm. I don't know. I know that Lehigh Valley has one. I don't know if anybody knows if St. Luke's has that as well.
Yeah, St. Luke's has the hugs tags too.
Okay, good. Any questions on the safety aspects? Circumcision, kind of the same thing. I don't expect you to be able to tell me the different devices. Don't worry about that. I put that in there, you know, just so that you can speak intelligently about it if you see it. So there's different, you know, it depends on the physician, depends on, you know, what they like to use and stuff. They do use the oral sucrose. They will also give a local for pain management. Back in the day, there was times when they didn't. They were like, oh, the baby don't feel it, but the babies do. They scream. And then afterwards, you want to, the two concerns that you want to watch for after circumcision is infection and bleeding. So you want to monitor for any signs and symptoms of infection. So the same thing, redness, swelling at the site, any signs of purulent drainage or anything that symbolizes that there's an infection. And I've kind of put it in bold here for you to really observe for first voiding, because of that manipulation and everything. It can cause some swelling, and we want to make sure that the baby has no problem voiding. Also, they will use a petroleum gauze and apply that at the site. They may already have like a pre-pregnated gauze pack, or they may just take a 2x2 and put some sterile petroleum gauze and apply that, and that's going to prevent bleeding and protect that site. Here on newborn screenings, the one I have it bolded for you. So they're going to do a whole lot of screenings. They're going to check for all kinds of disorders like PKU and maple syrup, urine disease, different things like that. But the one thing that's straight across in all 50 states is the hearing. Has anybody seen them do the hearing screenings? Yeah. So a lot of times in the hospitals, they'll have the technical partners do them. And basically they're not this kind like we have, like obviously the babies aren't going to like raise your hand if you know where you hear the sound, but it's more like an EEG where they're looking at like brain reactivity to the different sounds and stuff. If you ever get a chance, it's pretty neat. I usually tell my students on the floor if the technical partners or the nurses do it, I'm like, go with and listen, you know, when they're doing the hearing screenings. But that is the one thing, it's mandatory across all 50 states. It currently is, never know when things change. Vision screening is not done in the hospital. So just, I put here that it's done within a month. They confirm it. So if they check them like in a month, and then they will confirm it in 3 months and then treat around 6 months if there's any problems. And that's it. That's a mouthful, right? So this is just remind you to go back and do that best practice and newborn injection article and quiz that's under module 2, and then just upload your answers. I think I have it open the Dropbox, I think until Tuesday or Monday night. I think the 31st, I believe. I'll double check on that. Any questions over any of the content we talked about today? So to summarize, what are the things we talked about today? Like what were the concepts? What do we start off with? Jess?
I was going to say reflexes, but we didn't start with that.
No, that's okay. So reflexes, good. Good. So we talked about reflexes. What else? Carol?
Causes of postpartum hemorrhage.
All right, so we covered postpartum hemorrhage. Jess?
Thermoregulation.
Good. Mindy?
The breathing when the first breathing in the lungs for first round.
Good. Good. Just to kind of summarize, so your exam will be worth 100 points. You'll have to give you guys 2 hours and 15 minutes unless you need extra time. It won't be quite 100 questions. I think a couple of the questions are worth like 2 or 3 points. You'll have fill in the blank. You'll have some select all that apply. You'll have a case study, which has 5 questions. You'll have 4 medical math questions. So you can have a calculator. When you're doing all that scanning stuff, just show me your calculator. Here's my calculator. If you need a blank piece of paper, just say, I'll just pull a piece of paper under some, you know, like, here's my paper, just so I can see that it's blank. Some of you use noise canceling earplugs. Just make sure they're not headphones connected to your phone or anything like that. Any other questions about the exam that you might need? You all have my cell phone number, so I'll be watching it from my end. But if there's any issues, just if you need to call me, you know, I mean, I'm going to see because I'm here, but just say I'm texting you right now or whatever. Everybody has my cell phone number, right? Okay, so don't hesitate to get a hold of me if you need me. As long as everybody takes it on time, I should be able to get your grade. You're the last class.
Sierra.
So after you guys take it, I should be able to grade that and get those grades back to you by Thursday. And then, however, if you want to review it, whether good, bad, or indifferent, I can't show you the exact test. Like I can't pull up the test like I would normally, because unfortunately, students could screenshot it and whatnot. But I will go over to my best of my ability. So like say the question was on thermoregulation. I'd say, okay, we got this question on thermoregulation, and I'll go over some really key things that kind of help you so you understand what you did wrong. Okay, so I want, and I'll meet with you one-on-one. That wouldn't be like this. So, Rashida says, hey, I want to meet, even if she got a 93, because I want to find out, what other questions I got wrong. Then, we'll meet one-on-one using Zoom and if Carol wanted to meet and me and Rashida are still meeting, well, I'm not going to let Carol in. I'm going to say, Carol, you have to wait. I am meeting with Rashida right now. Any other questions? Did I miss anything? Mindy?
No, Sierra just wants to say hi. Go ahead.
Hi.
Hi, how are you?
Good.
What do you got there?
A guinea pig.
Oh, okay. I'm like, that's not a cat. Oh, what's your guinea pig's name?
His name's Max.
Max?
Yep.
And Jessica, you have a dog on your lap, am I correct? Aww.
Wait, is that the one that I like or no?
You
Wait,
like Well, if you guys don't have any more questions, what else I have? Whoops, that was it. As far as, let me just stop sharing here. There we go. Then you guys are good. I think, Jenna, you were going to stay on for a few minutes so I could go over what you need to do tomorrow, right, Jenna?
Yeah, because I missed the first couple minutes.
No problem. No problem at all. Anybody else have any questions? Email me. Reach out to me. As you're studying, you're not sure, I can certainly meet with you guys. I'm available for you. I'm a captive audience. I'm stuck here. So if you need me for anything, reach out. Don't be shy. And good luck next week. And do text me if there's any problems. Yes, fingers crossed, right? Fingers crossed, prayers, say the rosary, wish on a shooting star, all those things. All right, thanks, guys. Have a good night.
You too.
Jenna, I am going to share my screen again.
Okay.
I can pull up the directions for the thing tomorrow.
Is it for Alice training?
Yes.
Oh, can I stay too? Because I came in late. with the class.
Absolutely.
Thank you.
You're welcome. How you doing?
I'm doing okay.
Hanging in there?
Yeah.
And I just found out, I'll add to this. Okay, so to get to the directions for the Alice training, it's actually civility, I think is what they did. So Alice training, so it's right here. So when I came into Canvas, I went to the virtual clinical, and then I came down here. The reason I put V's next to it is because I was uploading all these onto Canvas, and I wanted to be able to make sure I uploaded everything that I needed. So I put V so I could find it easy. So if you're wondering why, that's the only reason why I put V's. It was just to help me because I had so many files on my computer. So basically, you're going to be doing the ATI civility modules. So when you go into ATI, there's going to be 4 of them that you're going to be doing. It's Foundations of Professionalism and Civility is the first one. Professionalism and Civility in the Academic Environment. Civility and Patient Safety in the Clinical Environment. And Professionalism and Civility in Nursing Practice. So you're just going to be doing all those 4 ATI modules. And
are they under the Learn tab or?
I didn't create them. Let's see if we can find them.
I didn't even get a chance to look for them yet, honestly.
Honestly, I didn't make this. This is the only assignment that I didn't create.
No, I think Ina did this.
Let me. Let's go under student view. I believe you go in My ATI.
Mm-hmm.
And then civility, would it be under, what did you think it was under apply?
Yeah, I think it's apply.
Oh, maybe they apply. That's what they're open under.
Yeah, apply.
There we go.
Yeah.
Oh, okay. So I'm guessing we just hand in our grades then?
Oh
yeah, probably, because it says begin. Because there's no like debriefing or anything with it or.
There's questions.
Is there questions here?
Yeah, Ina has it posted on her piece. Like it gives you direction of what you do.
Okay.
But there's questions after you do all the modules.
Oh, so there's questions after you do the modules. Okay.
Yeah.
It's under the PEDS thing though?
Yeah.
Okay.
Maybe I'll try and get that and post it under mine as well.
No, I was just wondering.
Okay, so Rebecca, you're saying it's underneath. Ina has other things other than these to do.
Yeah, I think it gives like you have Jenna. You know how we had to do was it well of a child?
Yeah.
You know, after we did all the module, the templates, you had to do like debriefing questions.
Yeah.
Yeah, it's the same thing like that.
Okay, that makes sense. I was just hoping I didn't have to do another 10 templates.
Yeah, I had to do 26.
You did 26 templates for this?
Yeah, I was due the same day. No, not for this. For
oh my god, I'm gonna have to start.
I had like 2
right
things
now.
to do, so it was a lot.
So I'm gonna have to start this right now.
I made it through.
You're still here with us.
Yeah.
So does that help, Jenna?
Yeah, it does. Yeah.
And Jenna, you heard the whole thing about how to do the
Yeah, I'm the NICU person, so I thought at first I was like, do I have to do this sim? But no, you did the NICU
one with the 4th, right? April 4th.
I think this for us is the 6th. Is it?
Or 6th. I don't know. All the dates are yes. So
yeah, we're the second sim group.
Yep. So Rebecca and you have it on the 6th, and I can certainly meet with you again closer to that if you want.
Okay.
If because you're probably doing focusing on one thing at a time, that's absolutely fine.
Okay.
So,
Yeah, I'm good with one thing at a time.
okay, that's so people were asking, they wanted to like just do everything all at once, and so that they wanted to meet ahead of time.
Yeah, like I just have to focus on this test and this thing due tomorrow. That's
I'm fine with that. Are you okay though with what you need to do for Monday for NICU?
Yeah, because we've been doing stuff like that for the. I've only done the peds clinicals right now, and they're all like they're similar to that. So
I did it that way. Well, first of all, we got approved to use the ATIs, and I thought I would rather stay consistent with what Professor Levin was doing because you're used to it. So once you start doing those, it's gonna be easy for you to continue doing that same process.
It's like the same exact thing. So
Exactly. And then what are you doing, Rebecca? You have a peds. You have a peds on Monday the 30th.
Yeah.
Okay. And then Saturday the 4th, Michelle already sent you guys your stuff.
Yeah, she did send us that.
To be honest, I didn't get to look at that yet. Like Jenna said, try to take one day at a time because I work in the nursing home. It's crazy there.
Really similar to like the peds assignments.
Yeah.
But talking about doing a pre and post conference. I don't know if that's like set in stone yet though.
For me or for
Michelle, Saturday the 4th.
Oh, okay. Okay.
She did send us the assignments, but she was talking about doing a pre and post conference.
Yeah, I think she definitely likes to do a pre-conference. I'm not sure she was kind of like left it up to you guys for post-conference, and that was something that Tina Van Buren really wanted us to do because she felt that it kept that connectedness with our students so that you're just not like thrown out into the World Wide Web on your own.
Yeah.
So you guys are good for tomorrow. You're good for Monday the 30th for your assignment, clinical. And you don't want to focus on anything else until after that. So why don't we plan on doing a pre-conference on Monday, April 6th at 4:30?
For sim?
For sim.
Okay.
All right, so I can kind of go over that with you guys.
Okay.
Could you just send an email reminder then?
Yeah.
Thank you.
Will do.
Thank you, Professor Gaynor.
You're welcome. You're welcome. All right.
You guys, appreciate you.
I appreciate you guys too. I miss seeing you guys face to face.
Yeah,
I miss the school. I never thought I'd miss going to work, but I love you guys, but just like, going to work per se. It's weird doing work. I actually think I work more here than when I go there because it just never goes away.
Yeah, when I don't go to class, I always feel like I'm missing something or I'm forgetting to do something. Like I feel so lost. I don't feel lost, but I feel as together as I can be, but it's
a lot.
It's a lot. I'm like, do I have to do anything today? Something due today? Or would
it help if I did like a weekly summary?
I think
Rebecca's saying yes.
Of just like due dates and reminders, that would probably.
Yeah. All right, let me write myself a note here.
Just even like a basic Word document.
Yeah.
Because we have so many emails, and like I said, I'm just constantly like going through so many emails just to find like when did she say this and when did she say this and the assignments thing you have it posted is nice because I can see what assignments are actually
right, but still, where did I put my notes I was taking tonight?
Like if I didn't see that newborn quiz thing in the assignments due on the 31st, I would have forgot about it.
All right, so I'm gonna just do like and maybe what I'll do is I'll put it in the memo as like I'll bold it, like I'll put it all in caps and I'll name it something like weekly reminder.
Okay.
Yeah, and if you could just like a list of like either assignments due or things we should be doing.
Yeah, I'll just do something like that. Just maybe I'll do it like on like a Sunday to a Monday, just so that you can say, okay, this is what's coming up this week.
Yeah, that's it. I mean, I'd rather take things week by week than look too far ahead.
Sounds like a plan to me.
Thank you.
You're
Thank
welcome.
you so much.
You're welcome. Have a good night, girls.
You too. Thank you.
Bye-bye.
Bye.